Hello everybody. So this is part 1 of joint movement for healthy gait and balance. In this, I'm going to predominantly focus on the functions and movements of the foot and ankle and the hip. Although yes, the knee, low back, it's all one big coordinated, very complex dance that we do every time that we're taking a step. However, the knee, which is a less mobile joint and is just a hinge joint, flex, extend, does have that screw home mechanism, but for the most part, if we manage and maintain healthy mobility, pliability, and strength of the feet and hip, the knee and low back, those issues, in my experience, tend to be more compensatory due to limited function at the foot, the ankle, and the hip. So it's a good starting point. Naturally, if I have people that have knee issues, low back issues, of course, I'm working there and addressing the anatomy of those structures. However, when I'm thinking in terms of healthy movement related to standing and moving and gravity, so gait, not just with walking and standing, but even running, we need to look especially at feet, ankles, and hips. Now, all that being said, you're best suited to go and look at as many reference guides as you possibly can. Videos, read your books. How profound is that? Look at as many pictures, absorb the content and material, particularly visually. For myself, seeing the visual nature of how these structures all coordinate and move together helped me a great deal. The anatomy and terminology can be very convoluted. It can be confusing. There are some terms used interchangeably. For example, even the muscle anatomy itself. These muscles on the lateral side of our shin. Classically, we're usually called the peroneus muscles. Peroneus longus, brevis, tertius. I tend to, when I teach, just because it makes more sense related to the bone. I know that the other one is related to the nerve, but to the bone, these are also interchangeably called fibularis, fibularis longus, brevis, and tertius. So in this video, I'm going to be calling these the fibularis muscles, okay? But that's just an example of some of the confusing elements. The way the gait cycle itself is labeled and titled can have some interchangeable terms. I'm going to be really simplifying that one a lot, speaking in terms of like a initial heel strike, the mid stance related to balance, and then swing phase of the gait. So heel strike, mid stance, and then swing phase as well. So just helps a great deal. Also, the big toe lift off, i.e. propulsion. So we'll be talking more about that here soon. First off, let's just look at the anatomy of the foot. Okay. Now, we got, of course, our digits, our phalanges, big toe being our first. So 1, 2, 3, 4, 5. That being labeled and related to the metatarsals as well. So first metatarsal, second, third, fourth, fifth metatarsal. Then we get to the actual tarsal bones themselves, all these little bones. Now the foot can be divided into the forefoot, midfoot, rear foot as well. Particularly related to, you might hear the running concepts of striking with more of a front foot dynamic, meaning that the toes are making contact first. Midfoot, meaning the whole foot is kind of making contact at once, and then a rear foot, i.e. heel strike. So it's a fair and good concept to keep in mind, that we have the front of the foot, this midfoot structure, but the midfoot to rear foot is divided here. All these small bones are part of the midfoot, but just talus and calcaneus are part of the rear foot. And let's go through all of those little bones. On the outside of our foot, and here's an interesting thing about the foot, is I tend to think that I think about the foot in being divided down the middle like this, in that I have the medial half and this lateral half. On the lateral side of the foot, the side of the fifth metatarsal, and you can see that fifth metatarsal, the smallest toe, yet it has a really big tuberosity and structure to it. Just about in some way, all of those fibularis muscles come down and attach onto that, as well as other muscles of the foot. So it's an important design element there. And you also notice that the fifth and fourth metatarsal interrelate, make contact with the cuboid, which then makes contact with the calcaneus. So fewer bones over here, meaning we have more structure, more stability. The medial half over here, related to the third, second, and first metatarsals, each of them make contact with their own cuneiform. So we can call this the medial cuneiform, the middle cuneiform, and the lateral cuneiform. You may see those labeled, intermedial, what have you, but the three cuneiforms articulate with an individual metatarsal. Then all three of those articulate with the navicular bone, which then articulates with the talus. And the talus articulates with the calcaneus, that whole structure of how the talus sits and articulates with the calcaneus, our big heel bone, that's called the subtalar joint. But it's the talus that makes up our ankle joint, along with the tibia and the fibula. And it's held in place there on the medial side of the tibia, is what we call the medial malleolus. And then on the lateral side, this big chunk of the fibula, that big knob there, gets called the lateral malleolus. You can see it holds on either side the talus, which then can produce our dorsiflexion, plantar flexion, and then our inversion, eversion. This is why we have more inversion than we do eversion, because of the nature of how these malleoli are structured. The bigger malleolus is the lateral malleolus. And so, that's the classic reason why when we sprain our ankle, it tends to be inversion, right? As I digress, let's go through those one more time. Our phalanges, metatarsals, 1, 2, 3, 4, 5. On the lateral side, cuboid. Then going from the middle of our foot, medial, middle to lateral, there's our cuneiforms. Articulate to those, the navicular bone, which articulates with talus, and talus articulates with calcaneus. Calcaneus is our big heel bone, which articulates at the subtalar joint with talus, but also articulates with cuboid here on the lateral side of the foot. Now, this is a perfect reason why the arch of our foot needs to be, and is by design, more pliable. So as we go further into this, the biggest element that I'm going to be focusing on is how important it is that we maintain first metatarsal phalangeal, meaning big toe. We need good big toe extension and flexion, as well as a pliable yet strong arch, a mobile yet stable arch of the foot. And then here at the ankle, we need effective and efficient dorsiflexion as well as plantar flexion. The most common issues we are going to see, though, is people are going to have, related to all various potential reasons of compensation. They could start at the knee, it could start higher up in the body. It could be a foot-related injury, ankle sprain, what have you. The most common compensation that we will find is limited big toe extension. We'll have a hypomobile big toe, hypomobile midfoot, specifically the arch of the foot, and there'll be a loss of dorsiflexion, too much usually of plantar flexion. So challenging these structures and helping our clients have more dorsiflexion, more big toe extension, and a good pliable arch is the best thing that we can do. Some things to be aware of is if somebody has an unstable arch, i.e. like a navicular drop, something like that, maybe related to an injury or some kind of fracture, then we might have to adapt. But in general, those are our most common issues. Now, the other component that we'll be looking at as well is what happens up here at the hip joint. So as we strike, we're going to have our initial strike and heel strike phase. And then as we make contact, the foot is going to have to adapt. We go from a supinated state to a pronated state as we shift our body weight from behind the foot to in front of the foot. Okay, so pronation and supination of the foot deals with many structures. The simplest way to think about it is it's how the whole foot changes shape and adapts related to our body weight being behind the foot when we're initially making contact to when our body weight is in front of the foot. What's supposed to happen as we make contact is the arch of the foot is exaggerated and supinated, and then as we put our weight solidly into the midfoot and shift forward, we end up with some pronation at the midfoot, specifically the arch. The arch needs to be changing shape. So as I make my initial heel strike, the arch should be higher, and then as I bear weight, it should flatten out. The reasoning behind all that has to do with the efficiency of that is related to how the structures of the arch related to the Achilles tendon itself help give us free energy by, if we can think of these, the analogy is as a spring, a loaded spring. As I load these springs by flattening this arch, so now that spring of the arch of the foot has been put on tension, and as I bring my leg forward like this, the tendon of the Achilles is now been put on tension. When I lift my foot, my whole leg, and this is when our body is essentially fighting gravity, the efficiency that gives us essentially free energy as we lift our leg and go into our swing phase is that those springs, the spring of the arch of the foot and the spring of the Achilles, recoil and give us some bounce. That's just a very general way of explaining it. Okay. Now, the muscles that we'll think about related to all of this, I talked about the fibularis muscles here on the lateral side, two of which go down past that posterior to the lateral malleolus. Okay? I tend to think of this whole anterior muscle section in two compartments. It is two compartments, but we commonly, and to our detriment, think of this as one unit. The shin muscles is one muscle compartment, and it's not. These lateral muscles have to do more with eversion and stability. These anterior muscles, tibialis anterior, extensor hallucis longus, extensor digitorum longus, deal with dorsiflexion and toe extension. The tibialis muscles, by the way, anterior as well as posterior, which is behind, underneath the Achilles, they also invert. So tibialis anterior and tibialis posterior both are antagonists to that eversion. They invert the foot. So there's a lot of, rather than getting too mired down into the muscle function, I'm going to try to stop myself from doing that. But remembering that we have this anterior compartment just lateral of the tibia. And then we have this lateral compartment comprising those fibularis muscles, peroneal muscles. On the back, with the calf muscles, we're looking at gastrocnemius, soleus, plantaris, and then underneath of those, if I can get this guy off, which I don't make any promises. So sometimes you won't hear plantaris being, because some people actually don't have it, but those, you more commonly you hear people talk about gastrocnemius and soleus, which are important. They, along with plantaris, come down and they become the Achilles tendon, specifically gastrocnemius and soleus. But we can't lose sight of and forget all these muscles that lie underneath of those. So tibialis posterior, flexor hallucis longus, flexor digitorum longus, all of which come down behind the medial malleolus. Let me get the bone. The medial malleolus, and come down here and essentially use that section between the medial malleolus and the calcaneus. That's a nice channel for lots of muscles and tendons to be able to go down into the bottom of the foot. And that's exactly what they do. They go behind that malleolus and down into the bottom of the foot, and related to everything from plantar flexion to toe flexion. So in massage practice, we just really have to keep those in mind as well. We can't be thinking, let's say, in terms of plantar fasciitis, one of the most common foot-related symptoms that we will come across. If we're having issues at the foot related to the midfoot function and structure, toe function and structure, then we need to also look up into the lower leg of the muscles, basically around the tibia and the fibula. Many of the muscles related to actual toe function are up here, and we tend to think a little bit too much about these big calf muscles, gastrocnemius and soleus, and we forget or do not know how to access the muscles underneath here, which do go directly down into the bottom of the foot. So that's the anatomy of those guys. Now we're going to look a little bit at the hip, and based on how I have everything set up here, I'm not going to be able to show the motion at the hip too well, but again, watch the videos, particularly that Vasily medical one. If I didn't state that before, be sure to check out that. It's VA. My computer did something goofy here. Okay, sorry. It's VASYLI medical. So VASYLI medical, Vasily medical, lower limb biomechanics. I think on YouTube, if you just look up lower limb biomechanics, it was a really good video in my opinion, but look up lots of reference material. Now, at the hip, the pelvis too, and we'll look in the future videos, I'm going to actually physically demonstrate using my own body, but the pelvis has to, think of it like a hip hike. Yes, the hips have to hike up, the lumbar spine has to laterally flex, and the pelvis as one unit has to internally and externally rotate. So there's a hip hike, hip drop, internal rotation, external rotation. There's an anterior tilt and posterior tilt, all of which has to happen smoothly at the pelvis, which then articulates directly with the lumbar spine and the hip joint proper. So like anything, this is all especially convoluted and complicated. This can be a reason for SI related dysfunction. Low back, SI joint related dysfunction is going to by nature have an accompanying compensation and or causal element at the hip joint. So if we can only do so much directly at the SI joint, especially if one side's like hypermobile and there's instability there. So it behooves us to look not just at the low back, which is where most of the symptoms are going to present themselves. We need to look at the hip as well. So the hip joint has, since it's a ball and socket joint, has a great deal of range of motion. But it also has a very deep socket, which can allow for some really good form stability, and that's how people will compensate. They'll tend to compensate into, I'm going to pretend with my hands here that I'm the socket that the head of the femur inserts into. When we externally rotate, we actually pull the head deeper into the socket of the hip joint. So people will compensate by naturally, if they have issues at the foot, the knee, the low back, or at the hip itself, will compensate by going into the external rotation. That then will cause the foot to get turned out, and all of the mechanics that should occur with proper foot and ankle motion get disrupted, which then is going to cause strain at the knee. Basically, it's one big domino effect, right? So proper hip rotation, especially internal hip rotation, which is essential for us when we're bringing our leg through the swing phase and getting our foot in front of us to properly heel strike, implant our foot, and then on and away we go with all of that. But if we cannot accomplish a good foot strike without good internal hip rotation. So all the muscles and structures related to the hip, the adductors and abductors, adductors, abductors, it's all one big convoluted dance that is supposed to be very efficient, smooth, and the structures all have to translate from one of being weight bearing in a closed kinematic chain, where it's more about stability, more about balance and stability, while the other leg that's being lifted and swung, all the structures now are supposed to be nice and pliable and mobile. And then once that foot strikes and we're standing on it, it has to go back to more of a stability structure. So these muscles have to really smoothly coordinate, shifting from one function to the other, as well as then we're dealing with all these agonists and antagonists, some muscles being synergistic in one movement and others not in the other. That's going to be, as I said that a little confusingly, but a perfect example of that is as I was talking about the motion, I just lost glute maximus. Yeah. And we'll learn that muscle in particular, glute maximus, as well as good core strength, i.e. Obliques, transverse abdominis. Most important strengthening exercises we can probably ever do for ourselves is to make sure glute maximus and our abdominal muscles are good and strong. With that, all the other muscles can perform the movement and balance related functions that they're meant to. We tend to compensate for weak core, weak glute maximus with these structures, low back muscles, adductors, which then limits free and efficient motion, then meaning we're going to end up with a more rigid foot, issues at the knee, again, domino effect. But related to those muscles, and as we're thinking about gait, the deep lateral hip rotators, so glute maximus, which fell off there, we take that away. The deep lateral hip rotators, although these do function as we walk and we move, but the smaller the muscle, the smaller the motion. So these also have a lot to do with stability. A great deal of the actual motion that occurs at the leg in the swing phase as we bring our leg forward and in front of us, so around and in front of us, and then back behind us, has to do with the coordinated effort between the adductors and abductors, along with the flexors of the hip and the extensors of the hip. So some interesting dynamics with this are that the anterior four adductors assist in hip flexion. So gracilis, longus, brevis, and pectineus all assist during hip flexion. Adductor magnus, the biggest adductor, which is most posterior, assists during hip extension, hyperextension. So even just here at the adductors, though they all fire together to help give us stability as we adduct, let's think during just like a standing phase for posture, they all work together then. But once we are walking, the front four and then that adductor magnus, that posterior one, actually are assisting separate motions. So during massage practice, we need to address this tissue because they are very important as synergists related to hip flexion and extension. Similar to that, glute maximus, which is the most important hip extensor, particularly when we go into hip hyperextension. Glute maximus is just always needs to be the most dominant structure. It needs to be strengthened, needs to be reinforced. We need to help relieve low back tension and high hamstring dominance. High hamstring, lumbar rector spinae are synergists with hip extension as well as hip hyperextension. But glute maximus should always be the most dominant one. The other glutes, though, glute minimus, glute medius, and tensor fascia lata, are our AB abductors. And glute minimus, since it's the smallest, produces a smaller motion and is more about just abduction stability. It has some other elements, but medius, for example, glute medius, the anterior fibers also facilitate hip internal rotation, as well as tensor fascia lata, which assists flexion and internal rotation. So we have this interesting dynamic that on the medial side of our leg, we have these adductors, which help synergize, which function as synergists during flexion and extension of the hip. And then over here, with the abductors, we have a coordinated synergistic element related to internal rotation, and in the case of tensor fascia lata, flexion as well. So we have to, during massage, find a way to work effectively at these structures and think about these motions. These are not just abductors. This anterior front half, glute medius and tensor fascia lata, assist internal hip rotation, which we need, as I indicated before, we really need that in order to have a good leg swing for efficient gait. And then tensor fascia lata, which is famous for being a part of IT band tightness, it also assists with hip flexion itself. So that's just kind of a general summary of the anatomy and some of the nuances of all of this. Now, all of that said, it can get so convoluted. The most important element we can think of in terms of massage practice is making sure we address all components of this tissue from multiple angles. And that's going to mean if you're predominantly working in prone and supine during massage, then you really need to change where the client's leg is so that you can access the medial and lateral compartments of this tissue. More specifically, you should be using sideline. If you're really going to be as effective and efficient as you want to be related to leg, lower limb related function, it's also interrelated that you're best suited to just changing the orientation of the whole client. So prone, sideline, both sides, and supine are going to just give you naturally a better angle to address all this tissue, while also incorporating as much passive and or active joint movement as possible during the session. If we can just kind of generally reduce the tone, make sure of all these structures, make sure everything is able to slip and slide efficiently and effectively. And any joint movement is also going to have benefits at the joint capsule itself by stimulating that synovial fluid production. That just means make sure you hit everything and move the joints around as much as possible. That will usually do you just fine. And then you can think more and more nuanced as time goes on. You can start thinking about the paired gait reflexes in relation from one leg to the other, from the leg to the opposing arm and shoulder, to same side limbs, upper and lower. There's a lot of cool nuances you can get into. Firing pattern reflexes, thinking about how VMO, vastus medialis, should be dominant during knee extension. Thinking about how glute maximus should be dominant during hip extension or hyperextension. Thinking that glute medius should be dominant during hip abduction, related to quadratus lumborum, essentially meaning that the hips should be strong and firing first, not the low back. Now, I don't want to belabor this too long, but I'm going to show at the foot itself why this can be so important in hitting these structures in multiple angles. So if someone's laying prone, I'm going to stand up. And if somebody's laying prone, we have our client laying like so. My hand's going to act as the bolster. This doesn't always give us the best angle to work at the arch of the foot itself. When I work on the feet in prone, I predominantly think about the lateral side of the foot. If you remember that first part of the lecture, I talked about thinking about this whole foot being divided in half. The fifth and fourth metatarsals related to cuboid, okay? Now, when I'm working on that foot, usually I have the bolster here, but I tend to get my hand underneath the toes just so I don't inadvertently smush their toes into the table. Regardless, and it's never going to feel good, by the way, to push too directly on the heel, on the edge of the calcaneus, or what we call the ball of the foot, the sesamoid bones of the first metatarsal. This area, what we call the ball of the foot, and the heel itself, direct compression doesn't feel good, and it doesn't really accomplish anything anyway. If we're going to work at the heel, I tend to do more squeezing mechanics, which I'll demonstrate. And here, same thing, more squeezing mechanics and joint movement. Anyway, this lateral side of the foot, if when I'm looking at the person's foot, and I just draw that line right down the middle, and I'm going to focus my attention on this outside segment with my compressions kind of predominantly, and I'm just mindfully thinking about cuboid and those two metatarsals. So what you're going to see, I'm going to put my fingertips, my middle finger here is tracing where my compression forces would be focused, okay? I start up here, just below the heel, and work my way down. Now, what I tend to actually use is maybe a soft fist for smaller clients. With larger clients, I just bring my forearm in. The edge of my elbow, the very tip of the olecranon there, basically sits right there along that line, and I'm thinking about pushing that cuboid. Just nothing aggressive. Rhythmic compression with some glides, but I'm predominantly thinking about taking the lateral side of that foot and just moving it back and forth. And I'm just visualizing cuboid related to calcaneus, cuboid related to that fifth and fourth metatarsal. Helping keep that pliable also is going to mean that I'm getting a shear force related to cuboid in those cuneiforms. And then when I'm focusing more on the arch of the foot, I know I've addressed this lateral side, and now I can look there. Now, we were talking about side lying. if I have a person laying sideline, and this would be the top leg. So they're sitting. This is the left leg. So I would have them bolstered like so. And I'll get this set in such a way you can see. That's okay. This top foot, I work the fibularis muscles, what have you. But if I get my hand, this bottom hand, just kind of hugging the arch of the foot, hugging the medial side of the foot. And now this top hand can glide over the lateral side. Same principle. However, now I have the whole arch side, those cuneiforms and navicular, and the front three, the first three metatarsals, all hugged in one hand, and then I can move that lateral side of the foot back and forth. And I'm thinking about, again, cuboid and the fifth and fourth metatarsals. I can just good gliding strokes basically over the whole top of the foot. And you can just see how I can get a great deal of joint movement by just anchoring here and gliding across and then pulling, pushing and pulling, pushing and pulling, while my fingers are making contact and creating some pressure into the arch itself. It feels great, but it just accomplishes a ton. Now, related to the heel itself, calcaneus. Now, that same foot, if I would walk around the side of the table, I just hug that whole heel. Just slide it right there into the palm of my hand, and then I can bring this hand over, and I'm going to be thinking specifically about that fifth metatarsal. So holding calcaneus, and then I don't have a good angle, but holding calcaneus, here's my palm, moving it out of the way, and then this hand, I just put my whole thumb down across the bottom of the foot, and I can just move it back and forth like that. So this is here, and then that's doing that motion back and forth. I just can't get a good angle for you. But anyway, this squeeze around the whole side, I basically follow a half moon around the lateral malleolus. Just squeeze the whole heel joint. Don't push on that tuberosity, but everything there, trying to apply pressure along that aspect of the tissue, just posterior to that tuberosity is again where those muscles attach. So applying some compression there, working my way up into I end up feeling like I'm squeezing the heel, the calcaneus, and then work my way up into maybe even squeezing and applying a little bit of a bend force into the Achilles tendon. So just a really good angle to create that pliability. From prone to the top leg and side line, I can really work that whole lateral side of the foot well. Now, the bottom foot and side line is where I can get the arch really, really good. So here's the bottom foot and side line, and now I can usually just bring a good old forearm and just work the whole structure. And I use my bottom hand a lot to cup and hug the foot. It feels good, but also I can kind of control the motion in many directions. And the idea is just pliability in as many planes as possible. These structures all have to do with moving as we